So the biggest thing is that, it's test don't guess. People can look very healthy on the outside. They can be very fit. They can eat a clean diet and they can still have a heart attack. I've taken care of patients who've, had heart attacks, shortly after running a marathon. So just because you're, quote, healthy from the outside doesn't mean your inside is healthy. So there's tests that you can do both biochemically, looking at the inflammation, the oxidation, so what's floating around in your blood at the time, and then looking at the arteries themselves. So if you have a high calcium score test and you're a marathoner, well, you go down the rabbit hole. Why is that? Maybe there's a genetic reason why they're, developing plaque, even though they're, a marathoner, but off many times it's, that person never fully allowed themselves to recover from their exercise. So exercise is a stressor. You stress the body, you let it recover. Stress the body, let it recover. If you're chronically stressing the system, your body is going to not be able to repair itself at night when you're supposed to be sleeping, and you're more likely to be, scratching up the arteries still.
Hi, Dr. Twyman. Thank you so much for joining the Reshape Your Health podcast. I am so excited and delighted that you're with us today.
Thank you for having me.
Yeah, we're going to start off. I want you to tell the listeners a little bit more about yourself and why you became a cardiologist.
So cardiology is just one of the most fascinating fields of medicine, in my opinion. So I graduated medical school quite a while ago, almost 20 years, and going through training, you go through all the different specialties, and cardiology just is the one that really stuck to me, that I, thought the organ itself was amazing, that this thing in your chest is beating nonstop for however many years you have on earth. And then the day of a cardiologist generally is pretty varied depending on what you want to do. I mean, if you want to see patients in the hospital and do procedures or do imaging, you can do that. If you want to see patients in the office and manage risk factors, you can do that. You want to do stress tests, you can do that. So every day could be a little bit different, and it's just been a fascinating ride so far.
Yeah, and it's awesome that what you're doing online. I've followed your stuff. You have really good content on YouTube and Instagram. It's been exciting to just learn as I've researched for this podcast. And I wanted to know, how has your practice changed since, you said you've been doing this a couple of decades now. So how has your practice changed from then to now?
So when I came out of my cardiovascular training back in 2012, I was a hospital-based physician. So I mostly was, taking care of people having heart attacks, congestive heart failure, abnormal heart rhythms, and had an outpatient practice, for the patients that, were seen in the hospital and needed follow-up care. But in the past few years, I was just more interested in really getting to the root cause of people's, disorders and trying to prevent the things from happening in the first place. So 2 years ago, almost to the day, I decided to launch my own practice. It's named Apollo Cardiology. Apollo was the god of the sun, and we'll probably get into a little bit later how important light is for your optimal health. So Apollo Cardiology is about 2 years old now, and actually today is day one in our new upgraded office. So we're offering a little bit more advanced, non-invasive testing to tell people, how healthy their arteries really are.
I was interested in the reasoning behind the name of Apollo. So thanks for telling us that. I wanted to talk about heart disease myths, or what are like the worst pieces of advice for either heart disease prevention or treatment that you're trying to fix in people's minds.
I'd say probably two things is that one, that cholesterol is all good or cholesterol is all bad. Some people say, cholesterol doesn't matter, and other people think that, statin should be in the water. And it's much more nuanced than that. It's need to be very personalized to that person's risk.
Mm-hmm.
But the other big thing is that, typically that a cardiologist is somebody you should only go see when you're having symptoms. Yes, I've taken care of very sick people, on the brink of death, but my goal is to not let people get that far. So there are preventive cardiologists, and you can kind of work with one that can look at you way before you end up, with chest pain, shortness of breath. But typically people need to know that, if you have symptoms, you definitely need to get checked out, but it's okay to see a cardiologist before that, just, as preventative maintenance.
Yeah, I think that at least where I'm a geriatric physical therapist, many of the listeners know that. And so I've seen people with end stage cardiovascular disease, and it's not pretty. It's financially, emotionally, and physically draining. So I'm all about prevention. I love meeting other practitioners that are about prevention as well. But around here it is, once you have a problem, then they refer you to the cardiologist. So I think that's really important for people to recognize. You don't have to wait to get sick to go to a really good doctor and reduce your chance of getting sick in the first place. So I'm all on board there. Now, when we were planning for this interview, we wanted to talk about the diagnostic tests and procedures that you recommend kind of in the first half of the interview. And then the next half is going to be treatment recommendations. So let's start with just the general signs of an unhealthy heart. What do we need to be watching out for both men and women?
So unfortunately, about half the time people present with their first heart attack had no symptoms before that. So that's why I say, test, don't guess, and go looking, 10, 20 years before you have that first event.
Yeah.
But if you're having symptoms, the most common cardiovascular symptoms are going to be fatigue, shortness of breath, some kind of pain, pressure, discomfort in the mid-range of the chest, which may or may not spread to your neck, your shoulders, your back. Or if you're somebody who's, pretty active exercising, you just notice that you're not able to do it as much as you used to be able to do it, meaning your exercise capacity seems to be decreasing. Sometimes it's just a general malaise. You don't know what's not, you don't know exactly what's wrong, but you just don't feel as well as you think you should. Sometimes this can be a cardiovascular, thing that's driving that. So, get it checked out before you end up having the heart attack or stroke.
Mm-hmm. Yep. So do the symptoms differ between men and women at all, or not so much?
It's a good point. Everybody has different symptoms, but women tend to have more of the atypical symptoms where they may not have the standard elephant, crushing chest pain when they're, doing activity. They may just be more shorter breath or fatigue. Sometimes they present with just some GI complaints, they'll have nausea or abdominal discomfort, and people, think it's just acid reflux, but it's actually a cardiovascular concern. So anytime you feel something from above your belt to your neck, you always have to be concerned that there's something going on with your heart.
Mm-hmm. It's easy because I feel like a lot of these symptoms can be attributed to something else. And that's why this testing that we're going to talk about is so important to pinpoint that root cause. And then people can take action, because I think when we know better, we can do better. In school, we learned about diabetic neuropathy, and I was fascinated to learn that they can have these silent heart attacks and not feel that chest pain. And we know that people with diabetes are more likely to develop cardiovascular disease, vice versa. So can you talk a little bit more about special indications that someone wants to keep in mind if they have diabetes regarding their signs of an unhealthy heart?
So almost by definition, if you're already diabetic, you're going to be higher risk for cardiovascular disease. The real nitty gritty way is that diabetics have a reduced redox capacity, meaning their ability to make energy in their mitochondria is decreased, and nerves require a lot of energy to run. And so if the nerves to the heart are damaged because of high glucose, they may not have the typical symptoms of pain, pressure in their chest, because the nerves that would normally give that sensation are basically numbed. So diabetics, are going to be higher risk to begin with. So they should be more aggressively, evaluated, how much plaque, if any, is already building up in their arteries.
Right. Because they might, like you said, their nerves could be not functioning correctly and not have the symptoms, the classic symptoms of a heart attack. So I want to know some other, maybe more uncommon symptoms of something that could be going on that could be an indicator that your heart may not be as healthy as it once was. What are some uncommon things?
So I'd say the most, bizarre one I've ever seen was somebody who had just extremely frequent hiccups.
What?
That turned out to be her anginal equivalent, and that person ultimately needed multi-vessel bypass surgery. I've only seen it once, and I had to look it up. That it's a very rare case report, but that'd be a odd one. But I think one that people may not necessarily put into their front radar senses is that for men it would be erectile dysfunction. So erectile dysfunction means many things, but it's not uncommon that it's due to a blood flow issue. And so if you have a blood flow issue to the penile arteries, it's very common that you're going to have blood flow issues to the coronary arteries or the carotid arteries. So it's many times ED is a canary in the coal mine that something's going on with your cardiovascular system.
That's interesting. And I want you had a cool Instagram post, ED equals ED, in the sense of endothelial dysfunction equals erectile dysfunction. Can you give a little bit more of a baseline knowledge level for people who might not be familiar with the endothelium and what it is and why it's so important for our vascular health?
So endothelial health is the whole key to the game. So the endothelium is the inner lining of your arteries. The endothelium is one cell thick. It coats your arteries, and it's basically like the skin inside the artery wall. If you took out all your endothelium, the surface area is reported to be up to about 6 tennis courts in area. So it's a very large organ. It's actually your largest organ. And the endothelium does many things. It's a protective barrier for what flows in the lumen and what gets into the walls of the artery. But it also releases many substances. And one of the most important substances that it releases is nitric oxide. Nitric oxide is a gas that causes the muscle and the artery wall to relax. So it keeps the flow healthy and keeps the blood pressure under control. But having healthy nitric oxide also somewhat acts like nonstick surface or Teflon for some people who still remember Teflon. So if you have high nitric oxide levels, whatever's floating in the bloodstream doesn't tend to stick to the artery wall. So there are different tests that can monitor your endothelial function. I think we'll get into those.
Yeah.
But the endothelial dysfunction is the first sign that somebody has something wrong with their vascular system. And sometimes this precedes them developing plaque in their arteries by decades. So if you find that somebody has endothelial dysfunction and you treat it, they don't develop the plaque in the first place. And if they don't develop the plaque, they're not going to go on to have the heart attack or stroke.
This just came to me. So would you equate identifying endothelial dysfunction decades before the symptoms of heart disease kind of equivalent to identifying insulin resistance or elevated insulin decades before symptoms of diabetes?
So much like insulin resistance, which depends on which organ you're talking about, it's insulin resistant, but typically you're going to see high fasting insulin levels long periods before you see high fasting glucoses, before you see high hemoglobin A1C. So by the time somebody has a high hemoglobin A1C, it's been many years in the process. So same way, by the time somebody fails a stress test because they have a 70% plaque in their artery or they have an abnormal CT coronary calcium score, they've had endothelial dysfunction for many years. So, at my practice, that's basically my main job now is to discover, how healthy somebody's arteries are. And it comes down to how healthy is the endothelium.
That's fascinating. I'm excited to get into that. But before we get into the testing on how we even know if our endothelium is healthy, I serve a lot of women around and after menopause, and we know that there's significant health changes. I wanted to know an explanation from you as to why a woman's risk for cardiovascular disease, including like heart attacks and strokes, goes up after they go through menopause.
So, the most basic reason is because estrogen is protective prior to menopause. Having healthy estrogen levels keeps the particle count, the LDL particle count, in optimal ranges, and tends to be that when the estrogen drops in the perimenopause and postmenopause state, the LDL receptor doesn't work as well, and then the lipid particles tend to go up. More lipid particles, basically it's like more cars on the highway, more risk that things are going to interact with the walls of your artery. If you damage that endothelium, you're more likely to start developing plaque. So it's mostly an estrogen story, but the one caveat is that not discounting the concern for breast cancer, but your breast cancer risk is I think still these days about 1 in 8. Your risk of cardiovascular disease is 1 in 2, 1 in 3. Wow. So your risk of vascular disease is much higher than your risk of breast cancer. So if you're getting yearly mammograms or whatever type of cancer screenings that your doctors are recommending, you also should be getting your heart checked out.
Okay, and we're going to talk about getting your heart checked out, but I just want to clarify something. So you said after menopause, the particular size of the LDL shifts. And are you talking about before menopause, they're more likely to have the pattern A or the big buoyant LDL pattern, and then after menopause, they might shift to the pattern B or the small dense ones that can kind of disrupt the arterial wall a little bit more? Is that what you mean by the patterns?
It's actually probably more the total particle number or the ApoB containing particles. So previously it was thought that the size of the particles mattered, but when they actually did the analysis, if you just look at the ApoB containing particles, if it was large or small, they're both pretty much equally atherogenic or likely to form plaque. So yes, people still want to know, do they have, quote, big fluffy LDL or small dense LDL? It matters, but the main thing that, in that instance is if they have small LDL, it can point you towards, maybe they are becoming insulin resistant.
Okay. And so will you repeat that just one more time on what shifts after menopause, just so I can solidify it in my brain and do a little bit more research on that?
So it's my understanding is that, when the normal estrogen levels decrease in the postmenopausal state, is that your LDL receptor doesn't work as well, and you just don't clear the LDL particles from the bloodstream as effectively.
Okay, I will look into that more because that's not something that I've covered on the show before. Let's get into these biomarkers or tests that are important when it comes to determining someone's risk for heart disease. Which ones are your go-tos?
So I typically talk of three main tests to look at the health of your arteries. I may kind of include a fourth one, and now actually probably adding a fifth one to the practice now that I have the space to run it. But it's kind of like stops on a train station. Where are you on it? I mentioned earlier kind of a stress test. That's kind of a bread and butter test for cardiovascular practices. But by the time you show up for a stress testing, like put you on a treadmill or some other type of exercise device and see, can they recreate your symptoms? Do you have EKG changes while you exercise? Or if they're doing some type of imaging, does the heart not perfuse it properly or not contract properly if it's an echocardiogram? So they're basically looking for late stages. By the time you fail a stress test, you likely have a 70% blockage in one of your three coronary arteries.
Wow.
So we want to find you way before that episode actually happens. So we were talking earlier, the endothelium is the key to the game. So how healthy is your endothelium? Your risk of endothelial dysfunction, basically starts at birth, depending on, what your risk factors are. So, I sometimes I'm checking people in their 20s for their endothelial health. And, one test you can do, there's, salivary nitric oxide strips that can tell you, is that pathway working appropriately? And then the other way you can look is looking at a non-invasive way at arterial hyperemia. So how much blood flow returns to an area after it had the blood flow temporarily cut off. And you can do that with a test called the EndoPad. It's a non-invasive 15-minute test that looks at the flow in your fingertips. Then you have a blood pressure cuff that goes above your systolic blood pressure. So the blood pressure is higher than your flow. So you get that pins and needle sensation in your hands for a couple minutes. Then when you open up the blood pressure cuff and the blood rushes back in, you get this reactive hyperemia, meaning that the small blood vessels see this volume of blood and be able to dilate, they have to release nitric oxide to accept the volume of blood. So you can monitor how well those arteries respond under stress. And if you have healthy endothelium, then you're likely not to lay down the plaque. So that's the first test. The second test I typically recommend patients consider is called a carotid intimal medial thickness scan, or CIMT. It's an ultrasound of the carotid artery. Some people might be familiar with a carotid duplex ultrasound. Mm-hmm. That's, again, another kind of late to the game type of finding. You're measuring flow with that ultrasound. And it's kind of like a garden hose. You put your finger over a garden hose and it whooshes when you put your finger over it and obstruct a lot of the flow. Well, that's what the carotid duplex is looking for. So by the time you have a really bad carotid duplex, you probably have a 50 or 70% blockage in one of your carotid arteries. And that's mainly what they're trying to give you, is that data, is how blocked up is the artery. But using similar technology, but using a different software package, you can actually measure the thickness of the intima. And the intima is the layer of the artery wall that lies right below the endothelium. And if the endothelium has been damaged, well, the next layer to get damaged is the intima. And if the intima is getting thickened, well, then it's inflamed, your immune system's kind of activated. And then it's much more likely that those LDL particles or ApoB containing particles are going to start getting retained in the walls of the artery and dumping out their payload. So you can measure the thickness of the artery, which is a surrogate for vessel health. But the test also gives you an arterial age. So if you're biologically 40, but your vascular age is 65, you're essentially 65 years old. So you want to be more aggressive with your lifestyle, potentially supplements and medications to help stabilize that inflammation and if plaque is present. So that's kind of a midway stop on the subway. And then a later finding is that if you're actually starting to calcify plaques in your coronary arteries, and that test is done with a test called the CT coronary calcium score, or it's also known as a calcium scan. It's a low-dose radiation CT scan. It takes about a minute to do. And it's looking for calcifications on the walls of the three arteries that sit on the outside of the heart, called the coronary arteries. Calcium is normally supposed to be in your bones and teeth. It's not supposed to be in the walls of your artery. So if there's evidence of calcification in your artery, there's markers that you're having plaque deposited into the arteries. So generally 6 out of 10 people that do this study after the age of 40 is going to have an abnormal score. The higher the calcium score, the higher the risk. A high risk finding would be over 400. Over 1,000, person's likely to be symptomatic and may end up with some type of revascularization procedure, a stent or bypass. But I've seen patients up into their 80s still have calcium scores of 0. So just looking at somebody from the outside, you can't really tell how healthy their arteries are on the inside. So those are the three main tests. And then recently we started doing a little bit more testing in our office, looking at pulse wave velocity, which is an earlier finding, how elastic are the arteries. And then we're also looking at adding a test called the VO2 max, which some of the athletes would be familiar with. So, if you have a higher VO2 max, you have better cardiovascular conditioning. But the VO2 max is a good surrogate for how efficient your mitochondria are. And your mitochondria, they do many things, but people like to call them the powerhouse of the cell. You have healthy mitochondria, you're going to have healthy heart function, because approximately 1/3 of your heart by mass are mitochondria. So the better you treat mitochondria, the better heart function you'll tend to have.
That was an excellent explanation. I wonder how many times he's had to say this before he really gets it down, like the intima, for example, and explaining the anatomy of a vessel is not very easy. So I'm going to try to put a picture of that on the blog post so people can do that. But you did an excellent job explaining which tests you recommend and why testing endothelial health can really be a much more effective way to almost like motivate that behavior change before you see symptoms. So really good information. And I think you probably surprise people, because when we think of heart health, often we think of cholesterol and blood pressure. And I wanted to talk to you about what are your recommendations for a healthy blood pressure reading, and what are the best ways to measure blood pressure? What are the most meaningful ways? So let's start with blood pressure, then we'll move to cholesterol.
Sure. So, what is blood pressure initially? So there's a number called the systolic blood pressure. That's the top number you get on a reading. And then the diastolic pressure is the bottom number on a reading. So, for example, 120/80. So 120 millimeters of mercury is the pressure as the blood is leaving the heart and going through the aorta, the blood vessel that leaves the heart. And then the diastolic pressure, the 80, is the blood flow in the heart when the heart is relaxing. So, the kind of difference is called the pulse pressure. But a normal blood pressure for most people should be 120/80 or less. And so I tend to kind of go against convention sometimes, is where I talk about, that high blood pressure really isn't a disease per se. It's just a marker that you have really poor nitric oxide production, or you're destroying your nitric oxide abilities. And it's something that there's something abnormal in your environment, because rarely is the disease just baked into you from a genetic abnormality. It's something in your environment you need to look at. You turn off the switch, the epigenetic switch, and then things start to improve. But probably should go into a little bit, how should you actually monitor your blood pressure? Because, if you typically go into a doctor's office, you're, looking for a parking spot, you run up to the office, they bring you back quickly, they slap an automated machine on you and say, you got high blood pressure. Well, that's going to be high for almost everybody. Your body was under stress at that point. So you want to do it in more of a kind of natural, relaxed situation to see what your blood pressure is initially. So the general recommendations are it should be in a rested state. You should be sitting in a chair with your back supported. Your feet should be on the ground. Your arms should be supported at heart level. And then ideally, it's done with a manual blood pressure cuff so that somebody is listening to the systolic pressure and the diastolic pressure. The automated machines can be accurate, but you generally need to have them kind of calibrated against a manual pressure cuff to make sure that it is truly, giving you the numbers you expect. Because I've seen numbers off, 30, 40 points, and people think their blood pressure is normal, and they come in and blood pressure is actually very elevated. And so you check the pressure, and then, if it's quote high, maybe wait a couple minutes, repeat it, and see, if it's still truly high, and average them out. So, throughout the day, your blood pressure is going to have circadian variability. So it's typically going to be a little bit higher in the morning, and it's going to be dipping over nighttime as your cortisol levels are decreasing overnight. And there's ways that you can monitor blood pressure throughout the day. If you're somebody who has hard to control blood pressure, or you have quote white coat hypertension, well, I only have high blood pressure when I see the doctor. Well, the one way to kind of prove that is true is you get to send somebody out with it's known as an ambulatory 24-hour blood pressure monitor, and it monitors blood pressure, 2 to 4 times an hour for 24 hours. And you can see a graph of, where they're having spikes or where they're dropping. And you can really see, okay, at home, their blood pressure is quote normal. And when they're under stress in the doctor's office or driving or whatever, it's elevated. Okay, well, then that's somebody you should teach stress management techniques, not necessarily throw more medications at. So it gets a little bit more complicated than just saying you have a high blood pressure, here's a pill. But there's many things that drive blood pressure, but it's ultimately, for the most part, going to come down to that, the body's not making enough nitric oxide.
That's very interesting. Thank you for clarifying all of that. Cholesterol is next up on the list. When people think about heart disease, they think about elevated cholesterol. Can you just give us a brief overview from your experience on what we need to be paying attention to regarding our cholesterol?
So first off, the big myth is that there's good cholesterol and there's bad cholesterol. There's just cholesterol. So cholesterol is a needed substance. Without cholesterol, you're going to be dead. You need cholesterol to make your cell membranes, to make your bile acids, to help digest your fats, to make your hormones. So with no cholesterol, you're not living. Now, where there's quote bad cholesterol would be that if the sterol is ending up in the walls of your artery and building up a plaque in the artery that contributes to a heart attack or stroke. So cholesterol is a fatty, waxy substance. It's like oil and vinegar. It can't float in the blood by itself, so it gets wrapped up in these things called particles. The particles are made in your liver. They're like ferry boats or cars. The cholesterol hitches a ride in there, triglycerides, which are energy, hitches a ride in there, and then the liver sends them out, and the cells that need it put out like a little receptor, download what they need, and then send it back to the liver. So it's more about the particles or the cars or the boats out on the highway or the waterways that you need to count. It doesn't matter so much the cholesterol that's inside that. The cargo is important, but the carriers are more important because it's the carriers that are actually the problem. It's the carriers, the particles that are the things that are getting retained in the walls of the artery and depositing that cargo into it. So you need to do more than just a traditional cholesterol panel. So everybody's probably had a traditional cholesterol panel before. And that's where you're going to get basically four numbers. You'll get a total cholesterol, an HDL cholesterol, a triglyceride, and an LDL cholesterol. They're good information, but you need a little bit more. So typically recommend people get at least a ApoB, apolipoprotein B, or an LDL particle number that tells you like how many cars are on the highway. And then there's some more advanced testing where you can look at, are those particles actually oxidizing or rusting? Because if that's happening, you're much more likely to be depositing those particles into the walls of the artery.
Will you go into that last part again? Because I don't think that I've heard about that. If they're rusting or oxidizing, will you talk a little bit more about that?
Sure. So, earlier we talked about, cholesterol and high blood pressure, hypertension are two, risk factors for cardiovascular disease. But honestly, there's 300 to 400 different things that can cause plaque formation in your arteries. But I learned from Dr. Mark Houston many years ago that the body has three main responses. It's inflammation, oxidation, and autoimmune dysregulation. So one of those things is helping scratch up the arteries, and then that's what's leading to the downstream effects of plaque formation. So oxidation, the easiest way to think of it is rusting. So if you cut an apple in half and you see it turn brown, that's oxidation. Oxidation is happening nonstop in you as you consume nutrients, as your mitochondria are basically the engines that are taking the foodstuffs and turning it into energy for you. So you're consuming the fats and the carbohydrates, and essentially while doing that, there's going to be smoke during that process, and that smoke basically is oxidation. So there's always going to be a certain amount of oxidation, but if you're hyper oxidizing, then other things start rusting faster than they should, and then your immune system gets generally activated. So if you start really oxidizing your LDL, there's a now fancier test called oxidizing phospholipid on ApoB. That is a very high risk factor that you're likely depositing a lot of plaque into your arteries if that stays high for long periods of time. So it goes back to that, it's not as simple as good cholesterol, bad cholesterol. Is the cholesterol actually getting stuck in your arteries? And if it is, why? Well, you're either inflamed, you're oxidized, or your immune system's turned on. You have an autoimmune condition, you have Hashimoto's, something that's driving that process.
And you mentioned inflammation as well. Are there certain tests that you do for inflammation specifically?
So the kind of the gold standard one most people have access to would be a high sensitivity CRP. That's a protein made in your liver. If your high sensitivity CRP is consistently elevated, sometimes it's a marker that you have an autoimmune condition or potentially even have a malignancy. You want your immune system turned on when you have an infection. So if you have a high sensitivity CRP that's over 10, and you've had a recent cold or something, okay, that's normal. It's a problem if it's chronically elevated. So that's kind of the go-to, but there's some more vascular specific ones, LPPLA2, known as the plaque test, myeloperoxidase. Both of those are a little bit more vascular specific. So if those are up, your arteries are more likely on fire than not. And then there's a few other ones that look at the oxidation. So you can do the It's a urine test, F2 isoprostatine over creatinine ratio. That basically tells you how likely you are to rust things.
Hmm. That is interesting. A lot of this is new information to me. I'm sure it's new to our listeners. I'm probably going to have to rewind and listen and look up tests. I get down these little rabbit holes of research when I learn something new. So you're saying that LDL, HDL, not as important as the oxidative stress and the inflammation that can contribute to how the cholesterol particles interact with the wall of the vessels.
Correct. So, I mean, it is complicated. There's LDL particles, there's HDL particles, then there's HDLC, and there's LDLC. Sometimes the nomenclature gets a little bit hard
Yeah.
yeah. So I generally kind of break it down to is, use cars on the highway. So, you want to know how many cars are floating around in your blood vessels. You got 60,000 miles of blood vessels. If you have more cars on the highway than you need, there's going to be a traffic jam in your artery somewhere. And they're dropping off the passengers. And the passengers are the cholesterol and the triglycerides.
Okay. I think we're kind of getting to the second phase, right? So, okay, this could be a problem. Well, what causes that? What causes too many cars on the highway, so to speak? But before we move on to like the treatment and the prevention recommendations, did you have anything else that you wanted to add to this diagnostic kind of part of the interview?
So the biggest thing is that, it's test don't guess. People can look very healthy on the outside. They can be very fit. They can eat a clean diet and they can still have a heart attack. I've taken care of patients who've, had heart attacks, shortly after running a marathon. So just because you're, quote, healthy from the outside doesn't mean your inside is healthy. So there's tests that you can do both biochemically, looking at the inflammation, the oxidation, so what's floating around in your blood at the time, and then looking at the arteries themselves. So if you have a high calcium score test and you're a marathoner, well, you go down the rabbit hole. Why is that? Maybe there's a genetic reason why they're, developing plaque, even though they're, a marathoner, but off many times it's, that person never fully allowed themselves to recover from their exercise. So exercise is a stressor. You stress the body, you let it recover. Stress the body, let it recover. If you're chronically stressing the system, your body is going to not be able to repair itself at night when you're supposed to be sleeping, and you're more likely to be, scratching up the arteries still.
That's interesting. When I was growing up, my friend and I would run at the rec center, and there was this guy there, and he was an amazing runner, and he would run probably 2 hours. He ran so much, he got so sweaty. He always brought a change of shirt. So he'd always change his shirt mid-run because it gets so sweaty. And he died suddenly of a heart attack. And it was just the last person that you would think of that would pass away like that. And I always kind of wondered, I wonder what happened, and like you said, you can never really tell from the outside. So test, don't guess. Really good segue into here. So I know on your website, you have a video series about the 4 pillars for heart health. Can you give us an overview of what those are? And then we're going to dive into each of them in a little bit more detail for people if they want to know how they can prevent a heart attack or heart disease.
So I typically talk about the 4 pillars of optimal health, including nutrition, exercise, stress, both physical and mental, and then sleep. So a lot of experts out there talking about what is the optimal nutrition regimen for somebody. I have a definitely different take than most. Exercise, it's going to depend on what your goals are. But the two that tend to get missed is, how well do you deal with your stress in your environment? You may not be somebody who wants to meditate or do yoga, but how much is your body sensing that stress? Because if you don't deal with the stress, it can be the thing that's driving your blood pressure. It can be the thing that's improving or increasing your insulin resistance by raising your cortisol. So figure out how much stress their body's under. You can do that with different tests. And then the kind of the big one that I think too many people ignore for too long is, they have that idea that, especially the busy type A personalities that, I'll sleep when I'm dead.
Yeah.
Well, if you say that too much, you're going to end up that way much sooner than you want to. So focusing on high quality sleep, rest and recovery, I typically talk about it. It's really all about your mitochondria. If you do the things that support your mitochondria, you're going to have a healthy health span, and you need optimal sleep for the mitochondria to repair themselves at night.
Okay, there's a lot to dig in, but we're going to start with health span. You know that before we started, I said, oh, I like that word. Let's talk about health span versus lifespan. So go into that just a little bit. And then let's start with, I think we'll just start with exercise recommendations out of the 4 pillars, and then we'll dig into each of them. So talk a little bit more if people have never heard about that difference of lifespan versus health span, because we know what it is being healthcare providers, but maybe someone doesn't.
Sure. So, longevity, is probably not worthwhile trying to attain if you're not feeling well up at that point. In some of my other talks, I sometimes will share the data that, I had a great grandmother make it to 106 years old, and it's my goal to try to beat her record. That's how I kind of got into the biohacking scene. If I do everything I'm doing, I probably have a pretty good shot of getting close to her, but she definitely didn't do many things right. And she ended up with some chronic diseases near the end. And the whole goal is not to collect a lot of chronic diseases. You just want to be old, healthy, and then basically fall off a cliff from a health standpoint.
Yeah. A steep decline versus that
Right.
steady, slow decline that really impedes your quality of life. And I always say, like, the ability to do what you want to do and be there for your family and your community. Your health is really central to I think, your overall well-being.
100%.
Yeah. So let's start with exercise recommendations to improve that health span, kind of make our health span match our lifespan. We don't want our health span to run out longer, before our lifespan does. So exercise, we know it's important. We know that you can start wherever. Like, we're going to give some recommendations here, but if that's beyond what you can do, I think anything is better than nothing. So I'm just going to preface that. But you had some really cool recommendations that I want you to share, things that I have not heard about before.
So first off, some people just really don't enjoy exercising, and I'm probably one of those. I mean, I was actually a college athlete, but I still don't like to exercise much, but I know the benefits, so I do it anyway. You tend to feel better after you do it, so it helps improve brain-derived nootropic factor. So, get out there and pick an activity that you can do long-term that you somewhat enjoy to do. But from a vascular standpoint, exercise is, the miracle drug. It's, one of the best things at improving nitric oxide. So back to the story of endothelial health. That's where exercise is benefiting you, is that as the muscles are contracting, nitric oxide is getting released from the muscles. It's getting released from the blood vessels as the blood is going around the circuit. So that's why, exercise is important. Now, what you do, that's sort of up to you and what your orthopedic abilities are, but it's very important to have both resistance or strength training, because your muscle mass is key to your metabolism. And then your cardiovascular health is important as well. But sometimes people get stuck in kind of the ways where they're just doing bike or cardio or elliptical, and they're ignoring the resistance training. So I usually tell people, focus on your resistance training first, and then build in the cardio afterwards. And then, I think we're going to go into a little bit is, there's differences between, interval type training and then kind of the low and slow zone 2 training. I'm starting to talk a little bit more about people doing the low and slow exercises again, because it's, potentially beneficial for the mitochondrial function. Low, slow exercise where, you basically can hold a conversation all day long at that speed. If you're rating it out of an intensity, it's probably a 5 out of 10 on an intensity. And then if you have capability to measure your heart rate while you're doing it, a rough estimate would be 180 minus your age would be the target heart rate goal for that. And then, how frequent? Generally 30 to 45 minutes sessions. And we'd like to try to get at least 3 hours a week of that type of activity. That zone 2 training helps with the mitochondrial ability to beta oxidize, or basically burn fat for energy. And the better the mitochondria can do that, the more efficient they can be eventually to burn sugar for energy. So you're just basically stressing the mitochondria to be more efficient at energy partitioning. And so you build that strong base of mitochondrial function with this low and slow exercise. Then you can go into the sprint type work if that's what you're truly interested in doing, and you're going to get a better result. But if you're exercising for a sport, that's a completely different thing. If you're exercising for longevity, it's all about supporting the mitochondrial function.
That's good news to me, because I'd rather walk than sprint at this stage. I wanted to know what sport you did in college. You said you were a collegiate athlete.
I played college the first year, and then the last 2 years I played lacrosse.
Wait, you played, what was the first one? The first?
I was on the tennis team.
Oh, tennis. Okay, awesome. Okay, so I wanted to talk about that. So that's different than what people may have heard before, that it's all about how many calories you burn during exercise. And you're saying it's really not. It's about your muscle health and your mitochondrial health. We need to do resistance training to build muscle. We need to do low and slow cardio. I like that recommendation. I think it's really simple and easy to remember, on 180 minus your age. So that's kind of that target heart rate estimate for this low and slow state for our cardio. Now, you also have here on a list that interval training is great for your health as well. So we don't want to speak out of both sides of our mouth and say go low and slow, but then also do interval training. But what are some benefits of interval training that you might not get from low and slow cardio?
So the biggest thing is that, it's just a time management hack. You get more exercise in a short period of time. If you're doing interval training appropriately, you're probably not doing more than 10, 15 minutes of it. But, if the audience is more somebody looking for a health span kind of angle, you need to build the mitochondrial base before you can do that type of sprint work. So if you think of like an engine of a car, if you don't tune up the engine appropriately and then you just floor it, well, how well are you going to do when you're flooring a car that's not tuned up? The interval training is going to be much harder to do at that point. I'm a fan of interval training. You're going to dump a lot of nitric oxide when you do it, but it's something that if somebody's a couch potato, that's not where they want to start at.
Mm-hmm. So starting at that low and slow, I'm going to have that mental image now when I'm doing my slow walks of nitrous oxide being released. It's like one more reason to get off the chair at the end of the day and go for a walk, or just walk throughout the day, right? So tell us about heart rate variability and what it is, how we can measure it, and why it might be beneficial information for us to know.
So heart rate variability is a very important metric of how much stress your body is sensing. So you have something known as the autonomic nervous system. So you may have heard of, the sympathetic nervous system and then the parasympathetic nervous system. So your sympathetic tone is your fight or flight response. So that's where adrenaline levels are going to be high. You're running away from an animal. And then your parasympathetic response is your rest and relaxation. So your vagal tone is very high. That's, after a meal, you're going to have high vagal tone. So, if you've had a, EKG or, you monitor your heart rate should not be a metronome where it's 70, 70, 70, 70. That's a heart that isn't, very responsive to the environment. The heart should be responsive very quickly. So as you breathe in, your heart rate should expand. You breathe out, it contracts as the intrathoracic pressure is changing. So larger heart rate variability, the better the stress response to the body. It's a good metric of recovery in athletes. So, one way you can do it is there's different, monitoring devices. There's, chest straps, there's different wristbands that can do it at this time. And you just measure basically the heart rate variability in yourself. You don't necessarily compare yourself to peers. It's, what is your heart rate variability? And so I'm not going to necessarily give you an exact number what it should be, but, if your number example was like 50, and you're always 50, okay, fine. But if all of a sudden your heart rate variability is 20 and it dropped, you got to figure out what kind of broke the day before. Maybe you didn't sleep well. Maybe you had more alcohol the day before. Maybe you had a late meal. There's something you did that kind of broke your heart rate variability the next day. And that's a day you probably don't want to necessarily go for your personal best in the gym. It just means your body's sensing a lot of stress. In these days of the pandemic, heart rate variability is one of the first metrics that gets broken when somebody's coming down with an infection. So there's a ring that was doing some studies last year that was noting that people's heart rate variability would change 1 to 2 days before they would actually start developing symptoms. So you can monitor heart rate variability. It's just a kind of early warning sign that, hey, check your environment with what's going on.
Is there a manual way that we can check our heart rate variability, or does it need to be with a device?
Has to be with the device because it's measuring the millisecond difference between the beat to beat of the heart.
Okay, interesting. So just kind of knowing your normal, and then if it's off one day, kind of figuring out why, and not maybe overdoing it with exercise because it's going to feel harder that day, and it's just not kind of going to be working against yourself a little bit.
Correct.
All right. I've been really looking forward to speaking with you about light therapy, this long word, photobiomodulation. This is a big part of your practice and a large part of what you advocate for. What is it? And you speak about using photobiomodulation before and after you work out. So give us an overview about what it is and how we can use it before and after workouts to optimize our results.
So as you said, it's a long word, photobiomodulation. So how do you use light to modulate or change your biology? Sometimes the colloquial term for this is, red light therapy. That usually gets the job done. But the old name for this used to be low-level laser therapy or low-level light therapy. So if you're, Google searching, there's a lot of terms for it. So if you look for LLLT, sometimes that's the data. But in the past couple of years, all the organizations are starting to try to call it photobiomodulation. So how do you use light to change your biology? We were born without clothes. not being inside. So we've kind of changed up with Mother Nature's plan. All your body systems are programmed by the light environment that they're exposed to. So, ideally, you would pretty much never be inside, and your body would always know what time of day it is, and you'd make hormones and neurotransmitters on cycle. Your circadian rhythms would be in check at 24-hour cycles. When you come inside and you're using technology, especially post sunset, your body gets different signals and you make hormones off kilter. You tend to have higher cortisol and your melatonin levels would be low and probably not sleeping as well as you want to be. So how do you kind of reset your 24-hour cycles, is key to longevity. But you can augment it with these devices, these photobiomodulation panels. There's also different wraps and devices that you can use to target the light therapy. But the main benefits of it are musculoskeletal in nature. That's what that has the most indication for and the most data. So the easy way to think about it is that, you basically shine these very specialized lights on whatever hurts, and the pain is going to be improved because it decreases inflammation and is bringing blood flow to the territory. The geeky quantum way that this works is that the different wavelengths of light knock nitric oxide off of certain parts in the mitochondria, and then energy flow is improved to the mitochondria. And then that nitric oxide can go out and then dilate blood vessels, which helps bring different things to the system, more blood flow to the territory, and more blood flow generally helps lower inflammation. So you can think of these red light panels as augmented sunlight, and it helps lower pain in that territory.
So do you use it before and after you work out to improve circulation and reduce inflammation? Or what are really the benefits around the workout time?
So the post-exercise one can help with decreasing the delayed onset muscle soreness that comes on a day or two after a heavy lift. But the kind of pre-treatment, essentially you put energy into the cells without having to put food into the body to make energy. And the other thing it does is that it helps the muscles fatigue less. So it's not saying that you're going to be able to lift twice as much weight, but you're likely able to do more reps before getting to fatigue.
That's interesting. Do you have a certain parameter, or I've never done this before, so amount of time that you have this red light therapy before working out?
So it is individualized to the device that people are using, and that's why it's a little bit challenging to give general recommendations with it,
Right.
because there's different wavelengths of light, so different colors that are beneficial. Then there's the different intensity. So think of that as sort of like, what is the temperature in the oven? And then there's the time, how much time. So, you couldn't put a turkey in the microwave for 10 seconds and be cooked, but you also couldn't put a turkey in a microwave for 8 hours and not fry it. So there is a certain kind of recipe that you want to shoot for, and it's going to be based off the parameters of the light.
Of the device. Okay.
Mhm.
And you also spoke of two other things really interesting to exercise. I promise we'll get to nutrition too, but this is new stuff to me. So limiting EMF devices and then limiting artificial light while working out. Those are two more of your recommendations. Will you talk about why those are important?
So first we'll do the EMF, so electromagnetic frequencies. So there's man-made and there's native. So the man-made ones are going to be your mostly your devices that you carry around in your pocket and such. So your mitochondria essentially have sensors that are always looking at the environment. If you have a Wi-Fi, Bluetooth-enabled device very close to your body, it's going to interfere with the mitochondria's ability to sense the environment. It's essentially like a radar jammer to your mitochondria. And when that frequencies of light, that's basically what EMFs are. They're just different frequencies of light that you don't see with your eyes, but your mitochondria senses them. It's going to drive oxidation and inflammation in the mitochondria. And if your mitochondria aren't working well, they don't make energy, then you don't operate as well as you want. So if you're an exerciser, you're going to have more fatigue with exercise, or you're going to have more pain in areas that don't have energy. So, EMFs, not saying that it's not amazing to be able to communicate with somebody around the world with this, but there can be a potential help toll from it. And the easiest way to kind of mitigate it is to not keep the stuff on your body unless it's absolutely necessary at that time.
I know this might be a silly question, but do those include our little AirPods when we work out?
It definitely does, yes. So
yeah, because it's going into your head. Yeah,
that's right.
The phone. Even if the phone isn't on your person, if you leave it in the locker, but you still have the earbuds in, it's still affecting your performance.
Potentially, yes.
Well, it's a little bit of a bummer for me, but I'll start making that change. I used to run half marathons, and so I'm thinking about distance runners and thinking about, wow, that'd be quite the change for them. Is there anything that they can do really to reduce the harmful effects of the EMF devices?
I mean, it really depends on how far they're willing to go. I mean, optimal would be don't use anything.
Yeah.
There are air tubes headsets, kind of like my physician's stethoscope, has earbuds and it has a hollow tube and that goes down to a chest piece. But there are ones that then have like little speakers in there that they can plug into the phone, and then it transmits the sound up to your head, so you're not having Bluetooth or other radio devices up near your brain. So that be one option, but you definitely don't want to have this thing sitting in your sports bra or your pocket when you're exercising.
Okay, well, I'm going to change that. Thank you for that recommendation. And then, really interesting, limiting artificial light. I mean, how do we do that if we're going to the gym to lift weights in an artificial light setting? Is that what you mean?
Correct. So I mean, the artificial lights that people try to live under is not the same way that you were put together through Mother Nature. So the high intensity LEDs and compact fluorescent lights put out a different spectrum of blue light than sunlight, and the blue light tends to be 4 to 5 times more intense than Mother Nature's, and that blue light is very dehydrating to the cells. It
Oh,
causes a lot of reactive oxygen species. This oxygen is the terminal electron acceptor in the mitochondria, and you make different reactive oxygen species depending on the light that the body is exposed to. So, exercising indoors is definitely not optimal. Now how the way you could sort of biohack it would be to leave off all the artificial light. If you have windows, just open the windows. And if it's, if you're somebody who's working out in an absolute cave, then potentially get one of those photobiomodulation panels, those red light panels, and just use that as your task lighting while you're exercising.
that's interesting. A little unfortunate. Like, there's not much that I can do about the lighting at the gym when I go lift. But a good piece of information, and again, something new. You mentioned blue light. So let's talk about the importance of blue light blocking glasses. I'm going to, full disclosure here, I'm ordering them soon, but I have not done it yet. And I need to, because my husband and I watch TV to unwind at the end of the day. And I noticed that it definitely affects my sleep, especially if there's any baseline anxiety or worry going on. I feel like the TV affects me more then. So, talk about these blue light blocking glasses and how you use them for your mitochondrial health and your sleep.
So now the first myth is that all blue light is bad, and that's not true. It's just that the wrong frequencies of blue light at the wrong times of the day can be an issue. And the number one thing it's probably going to affect most people is it's going to affect their sleep quality. So your circadian rhythms are your 24-hour cycles. It's mostly programmed by the light that enters your eyes and hits your skin. So in an ideal day, you would wake up, generally around sunrise. You wouldn't see any artificial light before sunrise. You'd go outside, you'd see 20 minutes of sunrise. You don't have to necessarily stare at the sun, but that morning light will be balanced blue, red, and green light. That blue light in the morning into your eyes hits a receptor called the melanopsin receptor. And when that gets stimulated, your body knows, oh, it's daytime. And then cortisol starts rising, which wakes you up and alerts you for the day. And so you want to have a rise of cortisol in the morning time. But what you don't want is to have high cortisol at nighttime when you're trying to sleep. Cortisol is that kind of fight or flight hormone. So cortisol and melatonin are somewhat like two sides of a seesaw. So melatonin is not a supplement that you take. It's a hormone that your body makes throughout the day. And it's making it during daylight hours, but it doesn't get released until darkness, and generally needs 3 to 4 hours of darkness before it gets fully released. So melatonin is initially made in your eye, and then later the pineal gland also pumps more out. So, wearing the glasses somewhat helps recreate an environment inside that Mother Nature normally intends for you to be outside. So when you use a device during the daytime, if you wear glasses that filter out certain wavelengths of light, your brain gets a signal what time of day it really is. Staring at a computer screen, a phone screen, basically gives your brain the signal that it's noon, and you pump out cortisol at kind of peak intensity around that time. And so during right now it is actually about noon where I'm currently at, and so that is to be expected. But if it's 9 p.m. where you're at and it's already dark outside, and you're staring at something this intense, your brain's going to signal that it's still noontime, and you're going to pump out hormones and neurotransmitters a different way. And your melatonin's not going to get released. So it's harder to go to sleep, and it's definitely harder to stay asleep when you have low melatonin. So the way to support melatonin being released is, post sunset, try to minimize the use of your devices, especially within an hour or two of going to bed. But if you're going to look at, some screens before, then, switch to the darker lenses, the red lenses that block all wavelengths of blue light and most of the wavelengths of green light, so that your brain gets the signal, oh, it truly is nighttime. Let melatonin start being released and let cortisol keep coming down.
Those are great recommendations, and you did a really good job explaining it. Thank you so much for doing that. We talked a little bit about exercise. We talked about how to optimize sleep with blocking the blue light and other forms of light in the evening. I wanted to talk about nutrition really quick before we have to wrap up. So what are your recommendations regarding nutrition for optimal heart health?
So I'll start off with saying that, nutrition is important, but it's not necessarily the most important piece of longevity. It's really about getting your circadian rhythms and your light cycles right first. Once you get that dialed in, then focus on your nutrition. And the nutrition is going to be very personalized. It's going to depend on a couple things. One is going to depend on your mitochondrial haplotype. You can find that kind of information on a 23andMe report, but that basically just tells you where your maternal lineage originally came from. You only inherit your mitochondria from your mom, and your mitochondria are your engines that basically handle your foodstuffs. So that gives you an idea of what foods you might be more optimized to eat. The second big fact that people need to know is, where are they living in the world? The light cycles determine what foods you should be eating that time of year. So eating a very seasonally appropriate diet. So somebody living on the equator, 12 hours of light, 12 hours of darkness, generally is going to handle a lot more carbohydrates than somebody who's living very north. Somebody who's living more north is going to have 4 seasons, and there's going to be parts of the season where basically nothing is growing. Those are the seasons that person's probably more likely to be ketotic, because up until 100, 150 years ago, you only ate with what you got outside your door. You hunted, you fished, you foraged, or you were able to store the food a little bit. You did not have fresh fruit coming from Chile up to Canada in the wintertime. That was not evolutionary possible. So your body didn't evolve to eat those type of foods those type of year. Eating a very seasonally appropriate diet where you're currently at. Then the big thing too is the circadian rhythms. Yes, it's programmed by light. It's also programmed by the timing that the nutrients come in. Your liver and gut need 3 to 4 hours to shut off at nighttime. So if you're having trouble sleeping, just move up the time that you finish your last meal so that those basically shut off for the night. And you're probably able to get a little bit better quality sleep. And then kind of, for the macros, generally defer to my colleague, Dr. Gabrielle Lyon, on the protein recommendations, but generally you need at least 90 grams of protein a day just to maintain your muscle mass. If you're trying to add muscle mass, it's going to be a gram per pound of body weight. And then the big thing that some people don't always focus enough on is getting enough DHA in their diet. DHA is not a fish oil capsule. It's eating oily fish or things that have high levels of DHA in it. DHA is extremely important for retinal health and brain health, but DHA is what helps basically transmit energy from your environment to your cells. So that's my kind of nutrition wrap up in 3 minutes or less.
I know, as I say, we're wrapping it up, and I know we could do a whole nother episode on nutrition and really diving into the science, but I wanted to ask you 2 quick questions, rapid fire, thoughts on statins, and then thoughts on a baby aspirin. So really quick, thoughts on statins.
So yeah, that's definitely a whole podcast on its own, but I basically say, so statins are tools, and use the right tool for the job. So if you already had a heart attack, a stroke, you have stents in your heart, you've had bypass surgery, statins are likely to help reduce your second event. So it's the right tool for that person. You're a 20-year-old woman with, quote, high cholesterol. Maybe it's not the right tool for you. If you don't have plaque in your arteries, you're probably not going to get a major benefit at that point. And then the second question, aspirin, again, somewhat of a loaded question. Already had an event, have stents. Aspirin's going to help, reduce second events. Younger, healthier, a lot of times the risk of bleeding outweighs the risk of having a clot form in your artery. And there's other gene testing, something, CONT genes can determine if you're a good aspirin responder or not.
I could really have another couple of episodes with you just to dive into a few things that we touched the surface on, but I know we're out of time. So please, thank you first of all for your expertise, and then let our listeners know where they can learn more about you.
Well, thank you for the opportunity to discuss with your audience. I mean, heart attack prevention is my passion. I left my hospital-based practice 2 years ago just to be able to focus on this, and I actually today is day one in my new office. I basically call it Apollo Cardiology 2.0 because this is the ideal practice I've always had in my head, where I could work with patients to get to the root causes of their cardiovascular concerns. So we have all the fun cardiovascular screening toys here. We have the EndoPath, the CMT, we have the Max Pulse, we have the VO2 Max test coming in the near future. But my main office is in St. Louis, Missouri. If patients want to work with me remotely, I do telemedicine consults. The best way to generally get in touch with me is on my website, drtwyman.com. Last name is spelled Twyman. And also that handle on Instagram, it's at Dr. Twyman.
Perfect. Well, thank you. I'll be sure to link up all of your resources in the show notes for today's episode. I will let you go. Have a wonderful rest of your day.
Thank you very much.